All right. Well, we're going to get going. So, welcome everyone to the start of the 2026 Vermont Center on Behavior and Health monthly lecture series. I'm Steve Higgins, the director, and we have a full venue for the season. So, we have lectures set up starting today through May, and then, of course, we'll take the summer months off as we always do. And we're going to start with an excellent lecture this morning. We have David Farabee, who is an expert in medication for opioid use disorder in the criminal justice system. And he has had a distinguished career. And we're really pleased to have David with us. And I've asked Tyler Erath to do a proper introduction. So, Tyler?
Thanks, Steve. It's my pleasure to introduce our speaker today, Dr. David Farabee. Dr. Farabee is a research professor in the Department of Population Health at the NYU Grossman School of Medicine. Dr. Farabee earned his PhD in experimental psychology from Texas Christian University in 1992. He then went on to become a research psychologist at UCLA in their integrated substance abuse programs and professor in residence in the Department of Psychiatry and Behavioral Sciences. In 2018, he became professor emeritus at UCLA and then transitioned to his current position at NYU. Dr. Farabee is an excellent researcher whose work now across decades has focused on substance use disorder treatment, mental health treatment, and service delivery in criminal justice settings, with an emphasis on translating research evidence into effective public policy. And so Dr. Farabee's impact on the field can be seen in his extensive record of publications and grants, where he's served as a principal investigator on numerous projects funded by the National Institute on Drug Abuse, the National Institute of Justice, the California Department of Corrections and Rehabilitation, the Smith Richardson Foundation, and Arnold Ventures. He's also the co-editor of several books on substance use treatment for justice-involved individuals, as well as the author of Rethinking Rehabilitation: Why Can't We Reform Our Criminals? Dr. Farabee is also a co-director of NYU's Beta Gov initiative, which is a partnership with government agencies to evaluate and improve social programs. And then, so as Steve mentioned, his grant-funded research most recently has centered on measuring the effectiveness and optimizing the administration of medications for opioid use disorder in correctional settings. And so with that, it's my pleasure to welcome Dr. Farabee. Thanks for joining us today.
Great. Thank you, Tyler, for that introduction, and thank you for having me today. Um, Delighted to talk about MOUD and carceral settings. I, as Tyler mentioned, I've really spent like the last 35 years studying, almost entirely studying folks in the criminal legal or criminal justice system, and how best to deliver psychiatric addiction treatments to them. And only about the last 10 years have I focused more on MOUD. Um, and I always feel like an insecure child who feels the need to make the following point, and that is, even though it seems like a really niche area to study, the criminal legal or criminal justice system as a whole is the number one provider of psychiatric and substance use disorder treatment in the United States. So it's an important area to look at, and from a public health standpoint, and also with regard to the unique implementation issues that you don't find in when you're doing the same thing in community settings. Um, so let me first get the are we gonna there we go. The obligatory conflict slide. There is nothing ready no skeletons in my closet aside from receiving medications, SETI meds from Indivior uh, and Alkermes. Uh, so I mentioned that that the criminal legal system is the number one provider of addiction treatment in the country, and there's a great reason for that. And now we'll focus more on opioid use disorder. Um, you you know you can't always get really recent data here on stuff like this, but uh, adults in jail or prison are about 5 times as likely to report regular opioid use than those uh, um, in the community. So in that sense, it makes it a very, opportune place to catch people who may be receptive to treatment and to disrupt their use. It may take several cycles, but it is a good point to intervene and hopefully disrupt. And excuse me, I'm going to move my I need to move my something here so I can see better. Um, so so when you look at so that's the criminal justice or criminal legal system as a whole. Now we can break it down further to what we talk about carceral settings, jails versus prisons, and those have that choice has very big implications. One, if you go with jails, you're going to get much bigger numbers. At about 16 times more people flow through jails on an annual basis as through prisons. Now, that 8 million that you see there for jails, it probably includes a lot of frequent flyers, but it's still, in terms of just catching people who are at high risk and high need for opioid use disorder treatment, jails are a better bet. In terms of the risk of overdose, people from prisons after they leave are at about twice the risk of an overdose as people leaving jails. And that's because presumably tolerance would be lower when you're incarcerated for a longer period of time. So in terms of, again, just from jails, numbers, and prisons risk, it depends on kind of what the primary focus is. Um, but this also raises an important point, and that is that jails and prisons aren't just a great place to catch people because of the high prevalence. Jails and prisons also increase the risk. Many of you, I'm sure, have seen like the Binswanger, and there's a number of. I give one here from Hilden, from Minnesota. But Binswanger probably is the most cited, that shows that you're 13 plus times more likely to overdose than your kind of community counterparts in the weeks following incarceration. Um, so it's good to keep in mind that you're not just capitalizing on a funnel, but that funnel actually increases risk of overdose, which is further underscores the need to uh, to to intervene. So once you've got them, once you have their attention, what does one do? Uh, and I apologize. I'm sure many of you are all too familiar with this, but I want to be complete here. There are currently three FDA-approved medications for opioid use disorder. Methadone, which is a full agonist and is taken orally. That was approved back in the 70s. You take it daily, and the requirement is you have to have the kind of meet the regulations for the criteria for an opioid treatment program, which the regulations are many. Some jails have them, but they are uh, quite onerous. And because it's a full agonist, there are concerns about bringing a full agonist into a carceral setting. Buprenorphine is a partial agonist. It can be taken orally or through injection. And I say here daily and monthly, but Brixadi also has a 1 week version for a shot. And fewer restrictions. Any prescriber who has a data waiver can prescribe it. And then naltrexone, which is also, I think that was approved back in the 80s for opioid use. That's a full antagonist, and it can be taken orally or injectable. I don't know of any correctional setting now that does oral naltrexone, but I'm sure most of you are familiar with Vivitrol, the 1 month uh, uh, injectable medication. Um, and any that has the fewest restrictions. There's no there's no recreational value uh, 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 to naltrexone. So any healthcare provider with prescribing authority can offer it. So there are a couple of things to say about these the elements of these medications that bear particularly on they're particularly germane to the treatment of folks in carceral settings. Um, First, with regard to extended release formulations, um, that means getting a monthly shot once people are, have been inducted. A monthly shot reduces greatly the staff workload for the healthcare staff. So that's always a selling point and an important one for getting jails and prisons to offer it. Also, it is possible, we hear this a lot, and there have been publications on it, studies that show that there is some stigma associated with opioid use disorder, and lining up to take your Sublocade, your Suboxone is a red flag that you are, in fact, you have OUD. So a monthly shot is much more discreet. Um, and then lastly, it's helpful for people who are being released from custody because this is a very it tends to be a very unstable population. In our research, we find a third to a half are unhoused or unemployed. Uh, and in fact, I did a study in California with people who had other psychiatric disorders, where about 60% were unhoused before being incarcerated. Um, so having something in your system as you leave is some provides some kind of bulwark against overdose risk, at least for the initial period uh, post release before you can link up with treatment. The other thing I wanted to comment on was naltrexone. Now, this is like I think it's been my experience that it's very popular in correctional settings and very unpopular with a lot of clinicians and academics. But you couldn't design a better, more appealing medication for correctional settings, and yeah, it's got several great advantages. One is a complete blocker. So especially if you're an elected sheriff, elected official, and you don't want to be accused of switching one drug out for another, or getting people, you know, high, and you can just say, well, we put them on a blocker. That's kind of your your you're addressing the need without the kind of attendant criticisms that might come from some people. As a result, there's no diversion risk. And when I say diversion, it means some people get it and then they are able to with the oral meds to not actually ingest it and then sell it when they go back to the central areas. Um, and then sorry, and it has fewer regulations, as I mentioned. So these are big positives for naltrexone. I'm going to do a fair amount of time today talking about naltrexone just because it is so popular in jails and prisons. Uh, Downsides are it requires a 7-day period of abstinence, of opioid abstinence. Well, that's a plus if you're dealing with people who are sentenced uh, in jail or people who are in prison. But it can be very difficult to ramp people up for that full amount of time in jail if you don't know how long you're going to be there. In other words, if they're just being detained. And it's not very popular, especially if there are agonists or partial agonists available as an option that when you try to randomize people to one or the other, buprenorphine versus naltrexone, you really winnow the study, the sample frame by requiring that people are okay with either. So those are important considerations and how they relate specifically to carceral settings. We'll talk about methadone first. It's the oldest. And this is a meta-analysis well, it was of MOUD provision, but this was done in 2019, so there wasn't really great data on naltrexone or buprenorphine, but they had RCTs on methadone, including both prisons and jails. And as you can see, and that vertical bar there is the odds ratio of 1. So, you know. Uh, People getting randomized to methadone were much more likely, the odds ratio is 8.7, to show up to community treatment. The folks and friends research did a lot of this stuff, like initiating treatment in jail versus waiting till they just making a referral when they get out. Big boost in post-release community attendance if you start before they release. And again, all this is methadone. Significant reductions in opioid use and injection drug use and bupkis when it comes to recidivism. And we'll talk more about that later. But that's you know, we found that, and my observation is you tend to find the reductions of recidivism generally when you have the big observational studies, and less so when you have the RCTs and with an intent to treat, uh, you know, analysis. Um, okay, so moving on. Several years ago, my colleagues Josh Lee at NYU and Robert Schwartz at Friends Research in Baltimore, and I, this was back when I was at UCLA, we did a cooperative agreement looking at, it was called Studies, Somatic Studies of Medication for Addiction Treatment in Correctional Settings. I remembered it. And so our study was based in the Albuquerque jail. Josh Lee's was in Rikers, and then the Baltimore City jail. And the studies were uh, all shared one arm. So everybody had basically treatment as usual, which even though we called it enhanced treatment as usual, the enhancement was like we would give them a flyer of community programs available in there, where they're from. But basically, treatment as usual, meaning very, very little. Um, and then two of us shared an extended release naltrexone arm. Robert Schwartz had methadone treatment, and and then two of us shared patient navigation, which is quite popular. I think continues to be. So we all independently wrote up our findings, but then we jointly we'd harmonized cooperative agreements. So we'd harmonized our findings, and with the primary outcome being um, meeting the criteria for opioid use disorder 6 months after release. So that was the outcome that we all shared, and then we combined the arms. So we had a medication arm. In other words, did you get naltrexone slash methadone or nothing? And patient navigation arm, did you get patient navigation or not? And if you're not familiar with this study, you're not alone, because it landed with an absolute thud. We had three RCTs that were combined, and I was telling someone recently, I published a study on parking decades ago that got much more attention than this analysis did. Absolutely nothing. But what we did find, and I guess the reason it's not getting any attention, is that neither the patient navigation nor medication condition, those randomized to those conditions, fared any better than treatment as usual in reducing their likelihood of meeting the criteria for opioid use disorder at 6 months post-release. It trended in that direction, but it wasn't significant. And um, Important caveats here, or things to note, that MOUD retention was quite low. I don't remember if I don't whether read through the abstract here. I know that in our study that looked at Vivitrol, we offered up to 6 months of medication, monthly shots upon release, and only 8% of the people in our sample who were randomized to that condition got all 8 shots. And that was just kind of consistent with, with everyone else. So retention was low. And another important point to make here is that buprenorphine was not included. We had methadone and we had naltrexone. Um, so let me Robert Schwartz did find in his study that there was it wasn't the primary outcome, but should just to be fair, he did find that people who were people on methadone were more likely to show up in custody, were more likely to show up within 30 days of release to continue treatment. Recurring theme. Um, okay, so a little bit more about this is actually a comparison between uh, extended release naltrexone or Vivitrol and buprenorphine. Naloxone, in other words, is just the sublingual daily buprenorphine. And this study was done by Josh Lee, and this is I think this might be the only one I did, that slide that I showed doesn't wasn't from carceral settings. This is from the Clinical Trials Network, huge sample. And what they found, if you look at chart A, that's the intent to treat analysis, and you can see a big advantage for people who are on buprenorphine. The y-axis is relapse-free survival over a whatever 6-month period. Um, Especially in the first few months, things tend to attenuate over time, as many of you know. But big difference favoring buprenorphine. But that obscures a very important implementation point, and this is why it's relevant to carceral settings, because it was pretty easy once you randomize people to get them on buprenorphine. You could just pretty much immediately start the protocol for naltrexone or for Vivitrol. It as I said before, it took a week before they would meet the criteria. So as a result, um, uh, I think it was 94% of the people randomized to the bupe condition were received bupe versus 72% and of those who were randomized to take Vivitrol. Uh, so if you move to chart B, you can see, well, if you look at it per protocol, those who got at least one shot of what they were assigned to, there's not much difference, or I guess really no real difference. Um, but that says a lot, though, about kind of the practical issues are very real and impactful when you're dealing with something that takes a long time to to get to the induction protocol. So that really favors the use of carceral settings for naltrexone. Um, but the big problem with naltrexone, and I alluded to this in our somatic study, and many others have found it. In fact, this is a review from folks at Johns Hopkins, a terrific review on extended release naltrexone, and it can be summed up basically with two main findings. Many who start it or intend to start it don't, and most who do start it don't stick with it. And that is the hell of naltrexone treatment. It is the I can't think of any kind of better example when I'm trying to explain the difference between efficacy and effectiveness to somebody. It's like you have something it's highly efficacious, but so few will either to get on it or remain on it that it winds up not being nearly as effective as I think we'd all hoped it could be. Um, okay, so this is a cooperative agreement. Many of you, I'm sure, are familiar with. It was under HEAL, the J-Coin Initiative, Justice Community Opioid Innovation Network that was earmarked money from NIDA specifically to study, at that point, opioids. I think they broadened it in J-Coin 2 to cover other things. And this is a study that I was involved with Josh Lee and others you can see there at the top, um, where we wanted to do a head-to-head comparison. That earlier comparison I showed you was extended release naltrexone compared to daily sublingual buprenorphine. I will say this, that daily sublingual is not exactly like a thing of the past now, because many people still prefer it. But nonetheless, we thought, well, here are these two are the show. Monthly, apples to apples, monthly bup versus monthly naltrexone. Um, so what we did, you can ignore the kind of the branch on the right, because that was a kind of a quasi-experimental arm. But on the left, you can see that I think it was 640 some odd people across 5 sites, randomized, all of whom were involved in the criminal justice system, and almost all were in jail or a combined jail prison system, and they had to agree to be randomized, and then they were randomized to either Sublocade or Vivitrol. The primary outcome for this was at 6 months. Study medication retention on the study meds, and we posed it as a non-inferiority outcome that bupe would not be any worse than naltrexone. I should point out that the reason that that may seem like an unsexy outcome, just looking at retention as the primary outcome, but there's two things. One, retention is so important, and I'll continue to make that point. Um, and two, with this population, if you try to follow them up and get a urine, and you wind up saying, well, we found 40%, and uh, and half of them gave us a urine, or we're relying on self-report, and half are incarcerated. It gets quite messy. Here is a very clean outcome. You left, and how many shots did you get? So if you go away, uh, uh, you are still counted in the data. So it's a nice way of being able to uh, count everyone in the study. And we haven't written this up yet. It's happening as I speak. And so the only outcome I have for you is that primary outcome. And as you can see here, retention by study condition, there's higher retention among those on extended release buprenorphine rather than those on naltrexone. So that's kind of interesting. Um, the other thing, two takeaways here are, in fact, the buprenorphine folks got about half as many, I'm sorry, twice as many shots as as those on Vivitrol. Uh, but the other big takeaway here, going back to my recurring theme, is about half never got any medication at all when they left, any study medication, at least. So it's not always the case that if you offer it, that they will uh, build it, that they'll come. So I will periodically step back here and talk about some big picture points. Here are some issues that concern that are unique to providing MOUD in jails. One, I feel like I've been had because one of the reasons that the whole line of work appealed to me because I thought we'd have a captive audience is not really true. Jails don't always have offer a captive audience. You jails are very kind of unstable populations. Some are senates, but about 70% nationally. In some jails, there's a lot of variation by jail, but nationally, 70% of people in jails are pretrial detainees. They can show up and they can be gone in a day or two. Um, and so detainees tend to be an ignored group. I'm sure you all know the old joke of the guy who's like looking for his car keys under the lamppost. And another guy walks up and says, well, I'll help you. Where'd you lose them? And he said, about 50 yards that way. And he said, why are you looking here? He says, because the light's better. And that's kind of analogous to what we're often doing in jail research. We'll say, well, let's focus on the guys who are senates, but we're ignoring the 70% of people who are flowing through the system and who, often, who also would benefit from having exposure to treatment. But about a year ago, and Divior, so I've talked about naltrexone and Vivitrol taking a week to ramp up, a week of abstinence as a requirement. But Indivior, who makes Sublocade, issued new guidance saying you no longer have to take a week or more to induct people onto Sublocade, the monthly version. You can now do it in an hour. So if they don't, if you give them, I believe it's 4 mg. If you give them 4 mg and an hour later they're not reacting to it, then you can give them the shot. So that's a game changer in terms of getting people onto buprenorphine, uh, even if you don't know how long they're going to be there. So here's a study that I'm doing with many of you, I'm sure, know Pete Friedman, Tom Stopka. Um, we are looking at pretrial adults who enter jail with a prescription. So they're already kind of the MO would be to just maintain them on sublingual buprenorphine. And we we can't, like, these are pretrial folks. We have to at least make sure that they're not going to leave that day. So if we know they're going to be there for at least 4 days, but we also rule out like some of the serious charges, so they're not going to be there for many months or longer. We find people who are going to be there for a few days, but they're still pretrial. They could leave soon. And we wanted to see, well, what if we randomize them to either continue on sublingual or see if we could give them a shot? And now it's much easier. When we started this, it took a week. Now it's much easier to give people a shot. And our primary outcome is, well, what is the percent of people released who have clinically can have some protection in their system? So they leave and they are not at an immediate, high risk of overdose. Now, this is a small study. We're not going to be able to look at overdose because the base of the rate is too low, but we can at least uh, compare, like, is it worth trying to get people on the monthly versus the daily, and does that in fact give them more more protection? Are we increasing their likelihood of or decreasing their risk of overdose upon release? And then we're also looking at community treatment, participation, and diversion while in custody and reincarceration. I we're still collecting, we're still enrolling people in the study, so I'm just telling you that. Watch this space. I will have outcomes in probably a year or less. But what I can tell you is quite surprisingly, what we think is great doesn't always map onto what the study population does. A lot of one of the big problems that we're having is getting people willing to be randomized to the long acting. Uh, they prefer the daily. And the sheriff says that's because they're diverting it. A lot of the prospective participants tell us because they don't like shots. They're just not comfortable with it. But we don't know what's going on. But the things that make great sense to me and our and to Peter and to Tom don't necessarily bear out. So again, stepping back. Um, Three big takeaways for carceral MOUD. It can be effective, but adherence is really low once they leave, and the signals dissipate after 6 months. Well before that, but by 6 months, you really don't find anything. Now, that's pretty typical of almost any intervention research that we do. But uh, it's good to keep in mind. And then formerly incarcerated people have very little interest in ongoing contact and support. I didn't really talk about the two studies that did this patient navigation, but I've done other studies too with people leaving prison who had serious mental illness. We've done the same thing with patient navigators, and they're happy to meet with us when they're incarcerated, and when they leave, they don't want anything to do with us. So as much as it makes sense to us, uh, and much intuitive sense as that intervention makes, we're just not seeing much of an effect. And then lastly, there's no robust effects on recidivism. I mentioned that before. We've not found it in any of our RCTs. Um, and the thing I would say about that is I think we overpromise on recidivism. I've written and bellyached a lot about this. I wish we would stop trying to use this as a selling point to jails and prisons. Is going to reduce recidivism. I think it's a big overpromise. And more importantly, I would say, nor should we care. I don't know of any other health problem where we would say, well, you've got diabetes. We could give you insulin, but what's in it for us? Only if it's going to reduce recidivism. We wouldn't do that. So it's just kind of reminiscent, a reminder that even not just recreational use, but substance use disorder is still kind of a gray area between, is this a real health condition or is it just bad behavior? Unfortunately, I think often we kind of view it as the latter. But if you really do believe that substance use disorder is a real thing that needs to be treated, we shouldn't require that it be predicated on some kickback for us in terms of recidivism. Um, let me just quickly check time here. Okay. Um, so if any of you, many of you may already be doing the research in this space, and if you're not, let me just give you a few issues to consider from a research standpoint. Um, there was a time where you could show up with study meds, and you could randomize people to nothing versus that, and they would be thrilled that it was the only way they could have a shot at getting a study medication. Now, the people, the prospective participants are savvy enough, they have enough exposure to kind of know that all three and have strong preferences. And many jails have access to them. We're struggling with this in the study I mentioned, the Initiate project in Massachusetts, where they offer everything, and we're getting them to randomize. A lot of people are saying, I think I'll just get whatever I want. Um, so when you do an RCT now in jail, it can be kind of artificial because you're getting people to get something that they may not have chosen, and they may have had a choice otherwise. And patient preferences is important. There's a lot of resistance institutionally to offering incentives and you kind of get stuck between like the jail or the prison saying, no, you can't pay them anything, and then the IRB saying, no, you need to give them full parity. So if you're paying people $100 on the outside, give these guys $100 on the inside. Well, that's crazy because they're making 20 cents an hour. That's really out of balance. But even if you win that battle, often the jail or the prison will say, well, you're creating problems here too by some guy, even if you're giving him $20 for canteen purchases, then that can create a lot of hard feelings and even kind of and predation in the jail or the prison. So it's complicated. I won't go into all the ins and outs now, but that's something to keep in mind. The FDA, if you have a neat idea where you're thinking, well, what about varenicline or methylphenidate or GLP-1s? I want to see if this has an effect on, and let's use people in jail or prison. You can't do it. The FDA prohibits using any medication off-label, testing any medication off-label for off-label purposes with prisoners, and prisoners means both jail as well as prison. I have to say I've been burned by this, and it sort of angers me. But I also realize, and for those of you who don't know this, that uh, up until the 70s, almost all of our pharmaceuticals were tested on prisoners. Uh, and so we have a very awful history on how we treated folks who are in and who are locked up. So I think, I think it's defensible to err in this direction. Diversion. I mentioned this before. If you're randomizing people and some people are getting sublingual and they're diverting it, then it really hurts your ability to measure an impact of that medication. Follow-up rates are low. This is a very itinerant population, as I mentioned before, high rates of being unhoused or unemployed, and they leave. They often just disappear. So we all want 70+% follow-ups. It's just next to impossible to do. And even when you do find them, they're often reincarcerated. So then this drives me crazy. And there are ways I'm happy to discuss later on or offline to deal with this. But if you just go into this and you say, well, we've done our study and now half of the people are incarcerated, but of the half that aren't, we found 40%. And of the 40% we found, half of them gave us a urine sample and only 15% tested positive. It's kind of hard to make sense of it. Um, and so there are ways to deal with that, but that's a really major complicating factor in doing outcomes research with folks leaving custody. In terms of clinical issues, there's as I mentioned before, low interest in having contact and support following release, and that includes, well, as I'll mention in a moment. So the idea that we'll check in with you regularly and make sure everything's okay, caseworkers or patient advocates just aren't as helpful as we would like them to be. Again, diversion for the same reasons, people taking it at either volunteering, seeking treatment, they don't need it, or needing it, but getting the meds and diverting it. Undermines the clinical effectiveness of what you're doing. Low engagement in community treatment. That is not unique to MOUD. That's if you refer people to psychosocial treatment, whatever it is, when they leave, they uh, 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 half or more won't continue in the community. And then high risk of overdose. I mentioned before, jail and prison actually impose a risk, an additional risk. And so you're really dealing as a clinician with an acute risk of people. If you not like, well, you're going to miss your blood pressure medication when you get out, you need to hurry up and find a community provider. This is quite the opposite. You're going to step out of the jail or prison and be at dramatically higher risk of overdose immediately. So there are a lot of pressure to make sure that from a clinical standpoint, a humanitarian standpoint, that they have some protection. Another one is motivation. Economists talk about stated versus revealed preferences. I mean, if a lot of people you're a lot of people come into jail with a prescription and they're already on treatment, and so you can continue them on, and that's one thing. But you have a lot of people who also show up who didn't choose treatment, who weren't really interested in it, and but they'll accept a partial agonist while they're incarcerated. but they're not really, you're not really dealing with people who would have sought it otherwise. And so that, again, you brought the treatment to them, they'll use it, but when they leave, they don't continue. And I'm not making this up. My very first publication was decades ago, was where I looked at motivational levels of three different very kinds of motivation between people who in community treatment who were legally pressured to referred by probation or parole versus those who ostensibly volunteered. Apparently, nobody really volunteers, but and the only difference, there was no clinical differences between the two in terms of drug use severity or anything else. The only difference was in motivation. So that's an important point to keep in mind when you're dealing with, when you're doing treatment research with a group that may not have sought it otherwise. And then the also, so the research and clinical issues, also institutional issues. Back to diversion, that's a big one. This is a survey of jails, again by a group at Hopkins. Um, and the number three concerns are diversion, reasons that they would not offer MOUD, or that they would be reluctant to it, costs of the medication, which are going down but still high, and the regulations. And then that, of course, refers primarily to the agonist and partial agonist. Another interesting finding in this survey is that if a jail only offered one version of MOUD, it was naltrexone. I was most likely to be naltrexone and least likely to be methadone. So that's really kind of the opposite if you were going to look at in terms of outcome effectiveness. But so I'm not an implementation researcher, but that to me strikes me as an interesting implementation question. Why are we doing the obverse if you're only doing one in jail or prison, then or jail, than what the effectiveness literature would suggest. Okay, so 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 what's next? I mean, I think I'll make bigger. We're kind of wrapping up here, but the I really struggled with this. I didn't want to just end there. I wanted to say, at least in my own mind, what I think is are exciting directions. One, and this may be throwing good money after bad. I already did an naltrexone study, but there is a 6-month version of extended release naltrexone that's already in stage one, phase one trials, sort of as of a couple of years ago. I don't know the current status, but that's something that I still, before I just ignore it altogether. I would love to see whether a 6-month version, relative to somebody taking a shot for 1 or 2 months, if you had it in your system for 6, would that be enough time to maybe rearrange your life in ways that didn't include a opioid use? It may also include hanging out with different people. I don't know. These are not these are just my musings. But I'm interested in that. I think that's definitely worth looking at. Um, Another one, GLP-1s. We're all familiar with them. I had pitched something to Clinical Trials Network for use with folks on stimulants, but there are already 3 studies on clinicaltrials.gov, 3 registered trials looking at GLP-1s for opioid use. One with a really small sample, but the other one showed that they were looking at it as an adjunct for MOUD, and another one just as a treatment. Tirzepatide, I can't remember which one it was, as a treatment in and of itself for opioid use disorder. I don't think any more than the 3 currently approved medications. I don't think it's going to be a panacea, but I think we can learn, especially if what you find as you see with other behaviors, with alcohol, with food and alcohol, if you find, okay, well, they're not stopping, but they're reducing. And obviously, NIDA, Nora Volkov, and others have pushed for other clinical endpoints, and maybe reduction in use would be a win in and of itself. Uh, so, lastly, coupling MOUD with contingency management. Now, I promise you that if I were uh, drinking beer with strangers, and they asked me what I would recommend, this would be one of the 3. I realize I'm preaching to the choir here. Um, for some reason, I can't. Uh, uh, as I will. Well, I can't seem to get to the next slide. Oh, here we go. Proof that I'm preaching to the choir. Uh, but this is so the first two things that I'm saying when I say what's next, I think those are two areas that merit further research. This one is like just like what's next. This should be a policy or a practice recommendation. I don't know why this is it's still so rare in actual practice, but the effect sizes that you guys found, you know who you are, were let's see, I wrote it down. A Cohen's d of 0.75 for medication adherence and 0.58 for opioid use. I mean, these are effect sizes, and these are rigorous trials. Uh, to get an effect size like that is really difficult to do and rare. And so, I think that there is a lot of again implementation research and figuring out why that approach is not being um, adopted. And I think there's big hopes. I will say just in conclusion so, that so what we're doing now with MOUD in carceral settings is the effects are good, not great. And I think that the future really is in one of two kind of categories. One, out of the just some completely novel thinking out of away from all the stuff we're doing now, something that I haven't thought of or no one else. And the other is focusing on adherence because if nothing else, if I've shown you today, I hope I've shown you that there's a big problem with getting people. You can initiate people, you can capitalize on the criminal justice system to initiate treatment, but getting them to continue after release is the real challenge. So with that, I will stop talking and open it up for questions.
Great. We have some questions waiting for you, David, and thanks for a great talk. Owen Murray had a question here early, so let's go to Owen first. Have you looked into incidents of non-prescribed route of administration of sublingual bupe?
Incidents of non-prescribed. So how many people are? Oh, like how common is diversion? Is that? Am I understanding that correctly?
I'm not sure if Owen's still in the audience. He or she could expound, but I would guess diversion.
Uh, if that's if I'll start answering the question, still I'm answering the wrong questions. Uh, I have it. We're doing that right now. We have two studies that are nested in my Massachusetts study that I mentioned earlier, where we're looking more closely at diversion because it's such a commonly raised issue. So we're doing qualitative interviews with folks who have left because we want to ask them after they leave jail about their diversion experiences, and also doing natural language processing of the narratives when they do an investigation of diversion in the jail to get a better sense of how it happens and with whom and blah blah blah. Um, Others have published on that. I know Tom Stopka and Elizabeth Evans and others have been ahead of the curve, way ahead of me, and publishing on that. But all I can say is that we're looking at it now, but we're still in getting IRB review.
Great. Then we have a series of questions from Tom Dalton. I'm going to begin with the first. Do you see a potential to use long-acting bupe as an alternative to discontinuation of treatment in cases where the incarcerated patient is suspected of diversion? Any studies on that?
I don't know about studies, but I know that in practice it happens. That is often the case that if you are, I think it's the case again in Massachusetts, where we're in Middlesex, where we're doing our study, that if you're caught diverting, then they don't just say that's it. We're cutting you off. They move you to the long acting version. I think that's a great approach to take rather than rather than ending treatment altogether.
I agree. That's impressive. I wouldn't have guessed that in the
Yeah.
in the incarcerated population. So that's great. That is good. So any studies used? Well, you ended here, but Tom wanted to know if there were any studies using contingency management to increase MOUD treatment adherence and following release from incarceration. I don't remember that. So
Oh, following release from incarceration. Yeah, I, I don't know. Maybe if Rick is on the called. He might, I know he's involved in helping people do that. We're actively seeking sites to for us to do just that, but we're
Yeah.
struggling. It's I don't have to tell many of you that CM, especially with with criminal justice officials aren't fond of it. And I keep saying we're not suggesting policy. Let's just see what kind of impact you get, and then you can choose whether you want to adopt it. But it's still,
David, it's just mind-boggling, this
yeah.
reluctance to use it despite overwhelming evidence, and I still don't really understand it. And then Tom's last question is, even if data is not strong 6 months post-release, is there data of benefit for MOUD while incarcerated, reducing death in the highest risk period in the weeks immediately following release from incarceration? So like a carryover effect.
Well, yes, but there is the big observational studies, So I think from like a public health big picture standpoint, and the observational studies, which I tend to I'm biased towards the RCTs, but if you look at the big observational studies, you see you always see an effect and reduced risk of overdose. I have to say, if some state came to me or jail system came to me and said, well, what would you recommend? Because the evidence is kind of mixed. I think I would say maybe what it was getting at is like, okay, this is not a panacea. I don't know about long-term solutions, but I do know their risk is highest the 2 weeks after they get out. So even if you treated it as just overdose prevention for that immediate phase of acute risk, that's there's an argument to be made for that in and of itself. But yeah, there is there is in big studies. You do find effects. Uh, it's just that the reason I don't I wasn't sharing those today, aside from my personal biases, because there are often selection effects in the folks who who are opting in for the meds uh, before they leave, and differential risk.
I had a question, just a methodological question. When you're powering for these studies, is powering for recidivism and powering for detections of improvements in post-release drug use one and the same? Or
No, I mean, we power them for use for some one measure or another. Well, I mean, that one we looked at, we were powered for the one with Josh Lee was for retention. Um, but I mean, overdose, you never use overdose as an outcome for reasons that you obviously know that just the base rate is too low. And recidivism, I mean, I guess if I were writing a grant to NIJ, I would make that but I'm just, I would just never, I include it because if you submit a grant with this population, they'll say, hey, how come you left out recidivism? But I keep saying to no avail that you don't really get a bang for your buck for recidivism. We need to quit making that like a front and center benefit. And I guess to power to find a effect for recidivism, you would just need maybe, many hundreds of folks.
yeah, that's what I anticipated. So I just worry a little bit. I understand completely why you have to include it to get your grants. And I would be doing the same, but I just worry about false negatives. So that the fact that the medications aren't changing recidivism may be that you're just not powered to detect whatever effects are there. So just, yeah, food for thought.
Yeah, I suspect you're right. I wouldn't surprise me that you find some small effect for recidivism at a really big, there would be significant at a really big, observational
Right.
study. But the effect is small enough. So if you have, you know, a few hundred people in a couple hundred people in 200 or 300 people, I'm trying to think of studies I've done. Uh, you're probably not going to find it.
Yeah. Yeah.
We got another question from Rick. Why aren't you doing the same thing for CM for stimulant use disorder in jails and continuing into community settings?
Yeah, well, I'm dying to. Well, first of all, the talk today was MOUD, so I didn't discuss that. But I wouldn't have had much to say if I had been talking about stimulant use because we've and Rick and I have talked, about this um, and expressed our frustration that I think I could get a funder to fund an RCT looking at people, stimulant users leaving jail or on probation or community supervision, um, because it does dwarf there's nothing else you can do that really moves the needle much. So here you have something that has been repeatedly shown to be effective, and here you have a population that is very high cost and high risk. So it's a perfect opportunity. And as I said, I know of a funder who would fund it, but you know, we can't seem to find a site that one has the numbers, the big enough numbers to do it, and two, the willingness to let us randomize it. And well, that's two. And three, when you tell them it's contingency management, that people circle the wagons. We'll find one, but we just haven't yet.
And David, we have a question from one of our postdoctoral fellows, Katya Nolder, and she wants to know if you have found strategies to increase engagement with service providers, practitioners following release. Katya is very interested in CM, as are many of us here. But any experience, any knowledge you could share?
Well, I haven't found anything, and I don't know, this is why I did, I wasn't being, obsequious when I talked about MOUD and CM, coupling them. It truly, I don't know of anything else I would recommend to somebody if they said, well, geez, we had such poor medication adherence, what are we going to do? I did find in a study years ago that, this is almost like a nudge of study that we found that people leaving prison with serious mental illness who were on psych meds. And again, adherence is very low. And we tried all different ways of getting people to show up and continue with their meds at the clinics. And the one thing doubled the odds of them showing up and testing positive. We didn't use self-report. We tested hair, I think, for the medication. And that was having somebody, a designated other in the community, and often they didn't have friends or family, but it'd be like the director of the board and care facility, or it could be an aunt if they're living with whatever it is, that we specifically designate a person that shares responsibility for them taking their meds, and that doubled the odds of testing positive for that antipsychotic when they, I can't remember what the follow-up point was. Um, so it may be rather than a nice patient navigator who's willing to help you, who just and they never get their calls returned. It may be a focus on kind of capitalizing on the existing infrastructure or the social networks that they have to say, okay, you specifically are going to share responsibility for encouraging that person to go back for yeah ongoing treatment in the community.
Excellent. And then probably our last question from Elias Klemper, one of our faculty. Thanks for a fantastic presentation. Do you know when drop-off in MOUD treatment engagement is most common after release from incarceration? Any thoughts on interventions to target the first appointment after release? Whether that would differ maybe from other interventions.
The big drop off is the very first is showing up the first time. It's and then it kind of goes down slowly from there. But you lose, and that's a recurring fact. You lose half just as they walk out of the institution. So that would be. I mean, I think you could really make a difference if you get them to show up for that first one. Um, and and that's just not been an area that I personally have had
Yeah.
studied, but it's an important one.
Yeah, great. Well, we're about out of time. So, David, I want to thank you for giving a really rigorous database, RCT-based presentation. I think it was terrific. So thanks very much. And thanks to our audience for attending. And hopefully we'll see many of you next month for the February Vermont's Center on Behavior and Health monthly lecture. That's a mouthful. But anyhow, thanks to everybody and see you. Bye-bye.
Thank you.